Bismillah ar-Rahman ar-Rahim. Today we'll speak about acute coronary syndromes, and from this acute coronary syndrome we'll discuss most of the category of ischemic heart disease from its beginning till acute MI. Ischemic heart disease comprises chronic stable angina, unstable angina, and acute coronary syndromes. To understand everything, the definition is very important. So for discussing, we would like to define what's acute coronary syndromes. So acute coronary syndromes, the definition are, it's a clinical presenting symptoms, or they are clinical presenting symptoms of prolonged angina lasting more than 20 minutes, not provoked by exertion, and the angina doesn't relieve by sublingual nitrates, neither rest. Based on the ECG, acute coronary syndrome comprises two components, non-STEMI and STEMI. So we have the acute coronary syndrome. It's a clinical presentation. The main presenting symptom is prolonged angina. What does it mean, prolonged? Prolonged means lasting more than 20 minutes and not provoked by exertion, not relieved by sublingual nitrates. So we have non-STEMI and STEMI based on ECG. So what's non-STEMI? The ECG category are as follows. Transient ST elevation, so it's transient, it does not persist. We have an ECG that shows an ST elevation, giving treatment to the patient and giving him rest in the emergency room, then noticing after that the ST on the monitor has depressed. Doing another ECG, the ST came to baseline. This is transient ST elevation. Second category is persistent or transient ST depression, T-wave inversion, flattened T-wave, or even normal ECG. So if there is prolonged angina and one of these categories, this will categorize the patient under the non-STEMI. On the other hand, STEMI, the ECG shows ST segment elevation, mainly due to complete occlusion of coronary artery. When they have this ST segment elevation in the inferior leads, for example, this means that we have inferior myocardial infarction. If the ST elevation occurs in V1 till V4, this is anterior myocardial infarction, and in the lateral leads, the ST is in lead 1, AVL, V4, V5, V6. This is lateral MI. Let's define now myocardial infarction. What's the definition of myocardial infarction? And I'm sure that all of you knows what's the definition of myocardial infarction. Simply, it's cardiomyocyte necrosis. It's necrosis of the cardiac cell in clinical setting of acute myocardial ischemia. When there is obstruction of one of the major or cutting of the blood supply to the myocardial cell, this will lead to cell death. And cardiac cell death means that in the circulation we'll find elevated cardiac biomarkers, mainly troponin and CK-MB. Thus, to confirm acute coronary syndrome, from all we have discussed, we had the following. Number one, the symptom is consistent with prolonged angina. The second is we must do an ECG, and the ECG will divide the patient or categorize the patient into either STEMI or non-STEMI. Then we have to do a lab test. Why? To show if there is elevated cardiac biomarkers, cardiac enzymes or not, mainly troponin and CK-MB. From what we have shown, a combination of criteria is required to diagnose acute myocardial infarction. How to diagnose acute myocardial infarction? Rise and fall of cardiac biomarkers, preferably high sensitivity cardiac troponin, and at least one of the following to diagnose the patient as having acute myocardial infarction. Symptoms of ischemia, which is prolonged angina, new or presumed new ST segment changes or left bundle branch block and 12-lead ECG, development of pathological Q waves on surface ECG, imaging evidence of new or presumed new loss of viable myocardium or regional wall motion abnormality, which is simply by the echo. What does it mean? That in order to diagnose myocardial infarction, we must have rise and or fall or consistent rising of cardiac biomarker with one of the following criteria: either prolonged angina, this will diagnose myocardial infarction, or new or presumed new ST segment changes or left bundle branch block, new left bundle branch block on 12 lead ECG, or rise and fall of cardiac biomarkers plus development of pathological Q waves on surface ECG. This will lead to the diagnosis of myocardial infarction, which is cardiac death, or obtaining an imaging, which is simply the echo, which is the tool that we can use in the emergency room, showing by the echo that we have loss of viable myocardium and there is regional wall motion abnormality. What does it mean? That if the anterior, we have anterior myocardial infarction, the anterior wall on the echo will have anterior akinesia or even dyskinesia. Number 5, which is the surest, is intracoronary thrombus, doing a coronary angio and showing that we have occluded coronary artery. I hope everyone is following now and it's clear. So definitions, let's go to the definition once again. We defined acute coronary syndromes, we have defined acute myocardial infarction, and now the definition of angina. What's angina? Stable coronary artery disease, or SCAD. It's chronic stable angina. What does it mean, chronic stable angina? To define any type of pain, we have the type of pain, the site of pain, what's the provoking factor, what's the relieving factor, the duration of this pain, and the referral site. So in order to diagnose the chest pain, it's due to coronary artery disease, which is angina. It must be the type of pain, squeezing or dull compressing. It's not stitchy, it's not localized. Site is the pericardium, which is the retrosternal. So usually it's retrosternal. This is the classic site. When we have inframemory, this is not typical the site of pain. Provoking factor, it occurs in exertion. And the relieving factor, relieved by rest or sublingual nitrates. The duration usually of the angina, the chronic stable angina, it lasts from 30 seconds to a few minutes, usually 3 to 5 minutes. And the referral site, we all know, it's the neck, lower mandible, left or both shoulders, left or both arms. What does it mean? We can have it in the left arm or both arms, left axilla, or which is typical, rarely in the right axilla, left or maybe both forearms, and the left interscapular area. So, in conclusion, that angina, it's retrosternal chest pain, squeezing in character or dull compressing. It usually occurs with known exercise. It's known provoking distance of exercise. For example, the patient walks for half kilometer, then he should stop because of recorded chest pain. This is known provoking exercise and relieved by rest. The patient stands still, or he used to stop for 2 or 1 minute, the pain subsides. This is the relieving factor, or taking 1 sublingual nitrate, the pain subsides. So this is the chronic stable angina. This is to summarize also chronic stable angina. Angina is stable when provoking effort is constant and the duration for relief of pain is also constant. It's clear now, okay? We spoke about chronic stable angina now and acute coronary syndromes, which comprises non-STEMI and STEMI. There are another category in between, which is unstable angina. What does it mean, unstable angina? So how can we define unstable angina? When the patient goes from stable to unstable angina. We have 4 categories. Angina crescendo is unstable. What does it mean, angina crescendo? That the same patient, he used to walk half kilometer in order to provoke his chest pain. Now he used to walk for 100 meters. Instead of stopping once in his distance in the morning, for example, he used to stop twice or thrice. And the duration of the chest pain also is prolonged. He used to stop for 30 seconds or 1 minute. Now he must stop for 2 minutes in order to get his pain relieved, or taking more than 1 sublingual nitrate tablet. This is called angina crescendo. Angina crescendo means angina of increasing frequency and or duration. Number 2, angina at rest. Angina at rest is also unstable. Angina post-heart attack, post-acute coronary syndrome, is unstable. What does it mean? That we have a patient that he suffered acute myocardial infarction. He was admitted to the hospital. He got his treatment. Then after discharge, while walking in the first week or second week or third week, while walking, for example, 100 meters, he used to stop because of angina. This we can't classify the patient. If he has these attacks 1 month post his heart attack, we can't say that the patient is stable. This is an unstable patient. Also, angina de novo for the first time is unstable because we are not sure how the situation will go. So 4 categories to have unstable angina. I think from all the definitions we had said, it's now clear the ischemic heart disease. We have chronic stable angina, we have unstable angina, and we have acute coronary syndrome, which is non-STEMI, and on the highest top, the STEMI, which is acute myocardial infarction. What is the pathogenesis of atherosclerosis? Most of these atherosclerosis, as we all know and we study from the coronary artery, for example, having a cross-sectional area, it starts early in life by fatty streak, then plaque formation. Oxidized LDL invade the intima, and there is a reaction inside the wall. There is self-defense from the media will migrate to the intima, with smooth muscle cell will migrate and form the plaque, which is increasing plaque by continuous invasion of LDL, formation of defense by the smooth muscle cell. This will lead to raising a little bit by bit, as we can see from the figure, from the intima. Then it goes into the lumen, then forming obstruction, which gradually it can obstruct when there is obstructive atherosclerotic plaque more than 50%. At this time, the patient comes with chronic stable angina. Either it will progress rapidly or it will progress gradually. Progressing to obstruct most of the lumen gradually will lead to unstable angina, which is angina crescendo. But sometimes we have unstable plaque. The difference between stable plaque and unstable plaque is, as you can see from this table, is as follows. The stable plaque usually have thick cap and shoulders and small lipid core. The lipid cell is huge in size. When there is a rich lipid core, this is a large plaque that grows fastly, putting attention on the intima that can rupture. And when there is rupture of the shoulder of the intima, here there is platelet aggregation, platelet adhesion, then secretion leading to thrombus formation, and this can transmit the patient from the stable to instability to acute coronary syndrome. I think this is clear now. I think by now everyone is following and the pathogenesis is in your mind. But let's speak about types of myocardial infarction. I don't want you to be perplexed or afraid. What's the types of myocardial infarction, type 1 and type 2? What's that? It's simply the etiology of the infarction. Why the infarction occurs, why the acute ischemia occurs, why the abrupt cutting of the blood supply to the cell leading to its death occurs. So type 1, which is the commonest type, is the atherosclerotic plaque module we discussed in the previous slide. The atherosclerotic plaque goes to rupture by erosion, ulceration, or fissuring. There is platelet adhesion, platelet aggregation, then secretion, leading to thrombus, leading to occlusion of the coronary artery and myocardial ischemia, as we can see from the following slide also. It will define this. Here is type 1 myocardial infarction. We have here the plaque rupture, leading to erosion with occlusive thrombus here, and this will lead to rupture of the plaque leading to platelet adhesion and then thrombus formation occluding this coronary artery. Okay, this is type 1 MI. So what's type 2 myocardial infarction? Type 2 myocardial infarction is rare, and simply it means that infarction with open coronary artery. It's not occluded like the previous type 1. We have an open coronary artery. So why an open coronary artery will lead to acute ischemia? Simply because there is imbalance between the oxygen demand and the supply. When the oxygen demand is high and its supply is very low, this will lead to cardiac cell injury or cardiac death if continues the imbalance to continue. So type 2 myocardial infarction is this module. Either we have non-obstructing coronary artery, but there is, for example, anemia or tachycardia or so and so, as we will discuss later, but there is atherosclerosis here. The artery is open, it's not occluded, but we had type 2 myocardial infarction, which is cell injury and cell death. Why? Because the demand of oxygen is high, the supply may be low. Vasospasm also. Prolonged vasospasm will lead to cell death. Also, coronary dissection, spontaneous dissection, will lead to myocardial infarction and myocardial injury. And oxygen supply demand imbalance will lead to this type 2 MI. So you may have common question in the exam, for example, causes of type 2 myocardial infarction. Enumerate the causes that may lead to infarction with normal coronary artery or open coronary artery. This is the question. So as we have told in the previous slide, reduced myocardial perfusion will lead to this type, may cause this type of infarction. What does it mean, reduced? What are the causes of reduced myocardial perfusion? These are all the causes. Number one, coronary artery spasm. Number two, which may be drugs or toxins, for example, heroin addiction, coronary endothelial dysfunction, coronary artery dissection, sustained bradyarrhythmia, for example, heart block. This will lead to diminished oxygen flow to the coronary artery, which may lead to injury, cell death. Hypotension, prolonged hypotension, severe anemia, respiratory failure leading to hypoxemia. All these may lead to reduced myocardial perfusion. Number two, increased myocardial oxygen demand. What are the situations that may lead to increased myocardial oxygen demand? Sustained tachyarrhythmia, severe hypertension, and severe, for example, all the hyperdynamic circulation or hyperdynamic states when there is excess of tachycardia may lead to this type of cell injury. Now let us speak about the risk factors for atherosclerotic acute coronary syndrome. And now I think you can guess, all of you, all the risk factors. We have two types of risk factors, modifiable risk factors and non-modifiable risk factors. The modifiable risk factors are, of course, hypertension, dyslipidemia, diabetes mellitus, obesity, smoking, mental stress, or sedentary life. Non-modifiable risk factors, including age, of course, elderly are more susceptible to have ischemic atherosclerotic coronary artery disease, as well as atherosclerosis anywhere in cerebral vessels or abdominal aorta. Male to female ratio is 2 to 1 or even 3 to 1 till the age of 50. And after the age of 50, it's once again 1 to 1, because the menses a little bit protect the hormonal the hormone in the females at this age will protect them. Genetics, of course, we have the family history of dyslipidemia and family history of sudden cardiac death and ischemic heart disease. Here is an important part of our talk today, which is the differential diagnosis of acute coronary syndrome. So in your mind, while examining the patient and taking history, in your mind, you should put all the differential diagnoses to be sure of your diagnosis later on and do it accurately as you could. We may divide them into cardiac causes, vascular causes, chest causes, GIT causes, or neuromuscular and miscellaneous causes. And this also is a common question in the final exam. For example, differential diagnosis of acute MI, differential diagnosis of acute chest pain. The cardiac causes, number one, is acute pericarditis, which is the pain is different from that of acute myocardial infarction, that it is stitchy usually in nature and usually increases with inspiration and relieved by leaning forward. Also, the pain of acute pericarditis occurs in patients with low likelihood of having coronary artery disease, for example, young age without any of the risk factors presenting with this chest pain may elicit the diagnosis of acute pericarditis. Number two is acute myocarditis. Patients with acute myocarditis will present with elevated cardiac troponin and signs of heart failure. And the ECG also, you may have some sort of ST elevation if there is acute perimyocarditis, and it's very important to diagnose the myocarditis and the pericarditis from those of myocardial infarction, because giving thrombolytic therapy, for example, in a patient presenting with acute pericarditis, this may lead to tamponade and later on several problems. From the third cardiac differential diagnosis of acute MI is the massive pulmonary embolism. As we all know, we have the pulmonary embolism into three categories, either showers, and this presents with chronic cor pulmonale, or moderate size and leading to occlusion of one of the tertiary pulmonary arteries, leading to pulmonary infarction and pleuritic chest pain. But when the thrombus is big enough, it may occlude one of the main pulmonary arteries, and this may lead to acute right-sided heart failure that should be differentiated from right ventricular infarction accompanying inferior myocardial infarction, because both of them presents with acute right-sided heart failure, and an echo may give a clue to the diagnosis when you can denote the pulmonary, or having an image of the pulmonary thrombus in the main pulmonary artery or one of its main branches. The treatment, of course, is different a little bit, but the thrombolytic therapy given in the massive pulmonary embolism is in a schedule that differs from that of acute myocardial infarction. The second category, which is vascular causes mimicking acute MI, are of course very important. Aortic dissection and aortic aneurysm. And in aortic dissection, you should have the diagnosis of aortic dissection and put it clear, because if you, for example, mistaken an aortic dissection and categorize the patient as having a non-STEMI, then giving anticoagulants and antiplatelets may endanger the patient's life when he presents with an aortic dissection and misdiagnosed. The clue here is the pain in aortic dissection differs a little bit from that of acute myocardial infarction, that the pain in aortic dissection comes from the start very sharp and sudden severe chest pain from its onset. The pain of acute myocardial infarction is a little bit stuttering. For example, the patient states that when he woke up in the morning, he had central chest pain that is so compressing, and then waiting for 1 or 2 minutes, the pain subsides a little bit. Then he got from his bed, he went to the bathroom, for example, when the pain regained, and it was so severe. So it's stuttering chest pain. The pain of aortic dissection, usually it's sudden and acute from the beginning, and it's so strong from its beginning. The patient states that something has blown into my chest, or something has, the pain is ripping into my chest. This is one clue. The other clue is the patient with aortic dissection presents with severe pallor, that you are expecting to have a low blood pressure, but taking the blood pressure of the patient, you will have elevated blood pressure. The patient is hypertension, so the patient is he looks in a shock while he's hypertensive. This may lead or give you a hint that the patient may be in aortic dissection. The third, that the patient, when there is interscapular pain and going downward, from upward to downward, this may elicit or provoke the diagnosis of aortic dissection. And it's very important to differentiate both of them, acute coronary syndrome from aortic dissection. Pain of aortic aneurysm, growing aortic aneurysm, is mimicking that of acute coronary syndrome. Chest causes, the third category in acute chest pain. Tension pneumothorax. Tension pneumothorax, the patients present with severe dyspnea and chest pain due to rupture of one of the bulli. For example, if the patient have emphysema or is heavy smoker. Patients of pneumonia and pleurisy also should be differentiated from that of acute coronary syndrome. Comes next is the GIT causes of chest pain, which is very important to diagnose also and differentially diagnose it from the acute myocardial infarction. We have the GERD, reflux esophagitis, gastric or duodenal ulcer, pancreatitis, and acute chest cholecystitis, acute calcular cholecystitis or mucocele. Of course, the most dangerous of them is the gastric or duodenal ulcer. As we stated before, that we have the imbalance between oxygen supply and oxygen demand that may lead to myocardial injury. Patients presenting with anemia due to bleeding peptic ulcer, the hemoglobin comes down to 7 grams, and the patient have a chest pain also, doing an ECG showing ST depression. So you rush, and the patient is clearly in non-STEMI, and starting the treatment of non-STEMI, including antiplatelets and anticoagulant, may endanger the life of the patient presenting with ruptured stomach or ruptured duodenal ulcer, which is life-threatening, and he must go rapidly to operative theater to solve his problem. So when the patient comes to you in severe pallor and you are expecting extremely in pain and you are already having the diagnosis of non-STEMI, get his hemoglobin. And if this hemoglobin is, for example, 6 gram or 7 gram or 8 gram, wait a little bit and please suspect that the patient may have non-STEMI due to imbalance between the demand supply due to rupture or bleeding gastric or duodenal ulcer. The last cause of the neuromuscular or miscellaneous causes of chest pain, acute chest pain, which is conjunctivitis, neural as herpes zoster, or functional when the patient is hysterical. It is very important part of in our lecture today is rolling in and rolling out acute coronary syndrome. It's very important to roll in or roll out the acute coronary syndrome. What does it mean rolling in, rolling out? This is, as I told you, the definition of acute coronary syndrome. It's a clinical scenario. It's a clinical presentation. It's clinical syndromes. So when you are responsible in the emergency room, you have a patient coming to you late at night, for example, at 1 a.m. or 2 a.m., having, oh, doctor, I am not feeling well. I have a severe chest pain. Please help me. Then it's your duty to roll in the patient in the diagnosis of acute coronary syndrome, or roll him out and assure him that he is not in a cardiac asthma or cardiac heart attack. From all the previous slides and from all the previous part of the lecture, now I think that the differential diagnosis is in your mind, and you must have a typical chest pain. The presentation, you have a patient with risk factors coming to you with central chest pain, coming to you retrosternal chest pain, and for example, sweating and all of that. You must do an ECG. If you have the patient with normal ECG, this does not exclude that the patient may be rolled in to the diagnosis of acute coronary syndrome. Doing cardiac troponins and CK-MB, so you must have cardiac biomarkers. Even if the cardiac biomarkers is not early enough, it's not rising, then, and the patient have continuous classical chest pain, you may roll him into the diagnosis and have another setting of cardiac enzymes within 6 hours. You may keep the patient under observation and doing serial ECG so as not to have a patient escaping from the diagnosis, and this is very dangerous. How to roll out the patient? Rolling out the patient with atypical picking localized chest pain, coming to you with atypical chest pain. There is no risk factors. The patient, there is no likelihood of coronary artery disease, for example, young age patient, a young female after psychic stress or psychogenic, pointing to you with, oh, I'm having a severe chest pain, shoulder pain, but it's atypical, it's stitchy. You may do an enzyme. If it is negative, troponin and normal ECG, then you can roll out the patient and assure him. And as I told you, rolling into the patient in the diagnosis is very important so as not to miss the diagnosis, and this may danger the patient's life. If you have a patient with typical angina, classic angina, there is a risk factors. For example, his age is above 50, he's smoker, he's dyslipidemic or diabetic, and having ST depression on the surface ECG, his troponin is positive. This will sure roll the patient into the diagnosis of non-STEMI. On the other hand, if the patient has typical angina, ST elevation on ECG and prolonged angina, you're going to roll the patient into the diagnosis of STEMI, especially if the troponin is highly positive. Now we'll come to the clinical examination. The clinical examination of myocardial infarction patient, or a patient coming to you with acute coronary syndrome, or even patient coming to you with unstable angina, or even chronic stable angina. The symptoms. The symptom is very important to take the good history and analyze the history, knowing all the differential diagnosis. So the history, when it comes with classic angina, this is the gold stone for the diagnosis. Maybe dyspnea or abdominal discomfort in elderly and diabetic patients. Remember that the elderly and diabetic patients, those 80 years of age or diabetic patients, they may not come with the classic angina. They may come with feeling discomfort, abdominal bloatment, or epigastric pain, or even dyspnea. By physical examination, of course, you may have the patient completely normal. The pulse, the blood pressure, heart sounds are normal, no any abnormality. On the other hand, when we have the patient with severe pallor, hypertension, or hypotension, or thready pulse, maybe in cardiogenic shock, you have the patient on the extreme with cardiogenic shock, or complication of myocardial infarction, the patient may present with mitral regurgitation or VSD due to septal rupture, or acute heart failure with galloping and pulmonary edema. I think most of the lecture now is clear, and now we'll go to the management, and we will simplify the management as much as we can, because it's a big story and big we'll talk much more about the management. So let it be simple and clear. Management includes the diagnosis, as mentioned before, of course, from what we have seen, and the treatment of, let's speak about the STEMI first. The aim of treatment of STEMI patients is to restore the coronary blood flow to the occluded coronary artery as fast and effective as early as possible. This is the aim of the treatment, because most of the patients coming with STEMI, they have complete occlusion of the blood supply. Maintaining this complete occlusion, for example, half an hour occlusion may not have severe damage to the myocardium. 3 hours occlusion, you will lose part of the myocardium. 6 hours of occlusion, you will lose a lot of the myocardium. So our aim is to restore the coronary blood flow to the occluded coronary artery as fast as possible. This could be done by either chemical or mechanical. Mechanical, what does it mean mechanical? This is better achieved by primary percutaneous coronary intervention, which is called PPCI, primary PCI, which is the mechanical way of reperfusion. This we are using a balloon dilatation plus stent, provided that it can be performed expeditiously. As I've told you, very rapidly is the important. What does it mean expeditiously? That you are estimating that you can save the patient within 120 minutes from the STEMI diagnosis. You will open the artery and get him free of this occlusion. We may use thrombus aspiration by a special catheter to aspirate the catheter from inside the coronary before stent deployment in surgery. So if primary PCI in its proper time, which is less than 120 minutes, cannot be performed, then fibrinolytic therapy, which is chemical reperfusion, is recommended within 12 hours of symptoms of onset of the chest pain, if the patient has no contraindication to this thrombolytic therapy. This figure is very important, and it will show you how you will manage the patient with acute myocardial infarction. Here the patient calls for the ambulance, for example. The ambulance, it should be diagnosed in the ambulance. If the patient has the classic pain, and if there is ECG inside the ambulance, then the diagnosis of STEMI should be done within 10 minutes. And when you get the diagnosis of STEMI within 10 minutes, then you can direct the patient and you estimate how far you are from a specialized hospital that will carry the primary PCI. If you have this distance less than 120 minutes, then transfer the patient to this hospital capable of doing PCI all over the 24 hours, and you'll get the patient inside the cath lab for doing primary PCI, and this should be done by wiring within 90 minutes. This is the gold standard to saving. Okay, if you are far away, for example, away from any hospital for example, in Matruh, for example, or away from hospital, estimating the time that you will reach this hospital after 120 minutes, then at that time you give fibrinolysis and start it within 10 minutes so as to perfuse it as rapidly as possible. This is in the ambulance. If the patient arrives by himself to non-PCI capable hospital, then you'll do the same. If you are estimating that the patient you're going to transfer him in a period less than 120 minutes, then transfer him and get him into another hospital capable of doing primary PCI. But if the distance is more than 120 minutes, then give him fibrinolytic therapy, and then at that time transfer the patient after giving the fibrinolytic therapy to a capable PCI center. Let's speak now about common question that what are the contraindications to fibrinolytic therapy? You must classify them into absolute contraindication and relative contraindication. So we have the absolute contraindication, which is all of the following: previous intracranial hemorrhage or stroke of unknown origin, ischemic stroke in the preceding 6 months, if you have thrombus in the cerebral vessel within the last 6 months, is contraindication to give thrombolytic therapy. Central nervous system damage or neoplasm or AV malformation, if you are knowing the history of the patient, is an absolute contraindication to give thrombolytic therapy. Recent major trauma or head injury within the preceding 1 month, GIT bleeding within the preceding 1 month, known bleeding disorders, excluding menses, of course, aortic dissection, non-compressible factors in the past 24 hours, for example, liver biopsy or lumbar puncture. All these are absolute contraindication. You are not allowed to give the patient the thrombus. The relative contraindication to fibrinolytic therapy is as follows: transient ischemic attack in the preceding 6 months, oral anticoagulant therapy, pregnancy or within 1 week postpartum, refractory hypertension, blood pressure, for example, 190 over 120. This is relative contraindication. You may get the blood pressure down and then give your fibrinolytic therapy. Advanced liver disease, infective endocarditis, active peptic ulcer, and prolonged traumatic resuscitation. If the patient is arrested and you have a prolonged traumatic resuscitation, you may have fracture rib. This is relative contraindication. So now you have the choices between thrombolytic therapy in the relative with its risk, or transfer the patient even if there is delay. This is figure also is important for the timing, because time is very important in a setting of STEMI. As I've told you that this is 0 from the diagnosis of the patient. So I have 10 minutes to act correctly, as I've told you before. If you have transfer the patient to a PCI center, then do it rapidly and get the patient, and be sure that you'll achieve reperfusion within 90 minutes. Reperfusion here means wire crossing the occlusion of the coronary artery. If you have the patient in a tertiary place away from the hospital, then you have the 120-minute estimation of time you are going to lose. If this is less than 120, transfer the patient to primary PCI. If this is more than 120, give fibrinolytic therapy. Bolus should be given and infused within 10 minutes. Don't lose time. And then you will assess the patient if this succeeds to open the artery or not by an ECG, relief of pain. If this should be assessed within 60 to 90 minutes. If failed, then transfer the patient to what's called rescue PCI. If even the patient has succeeded, then transfer the patient within 24 hours to have his coronary angio, even if you are sure that the fibrinolytic has succeeded to open the coronary artery. This figure also is very important, and it's like the previous slide. The time interval is very important, and when to do primary PCI and when to give fibrinolytic from the 0 to 3 hours. In the first 3 hours, they are both effective, but of course, primary PCI is preferred than fibrinolysis if could be done quickly and rapidly and efficacious, because this will restore the blood flow to the coronary sure and effectively. If you give fibrinolytic therapy, even transfer the patient to has his coronary angio. From up to 12 hours, primary PCI is more effective to get the patient free of ischemia. If the patient arrives, for example, after 10 hours, it's preferably to do primary PCI over fibrinolytic therapy. And if the patient arrives after 24 hours, for example, the primary PCI, if symptoms persist or the patient comes with hemodynamic instability or arrhythmia, then get the patient with primary PCI, but it's not preferable the fibrinolytic therapy here. Anticoagulant is very important, as I've said, so as not to have another thrombus after opening the artery. And could be unfractionated heparin in this dose or enoxaparin. Oxygen also could be given, oxygen flow meter, if the patient is hypoxemic only. Also, for adjunctive therapy for primary PCI and fibrinolytic therapy, you have additional drugs like beta blockers, lipid-lowering therapy, which is statin to stabilize the plaques. The beta blocker is to reduce the cardiac workload, and is inhibitors or ARBs to prevent remodeling later on and aneurysm formation. Also, you may have mineralocorticoids receptor antagonist in order, this is in patients with a failing heart, if the ejection fraction is 40, is beneficial. All these, the patient should maintain on this treatment as secondary prevention. It's better to divide the complication of STEMI into early and late. We have early complication, and like sudden cardiac death, which is the extreme complication, acute heart failure and pulmonary edema, cardiogenic shock, mechanical complication, rupture of interventricular septum will lead to VSD, ventricular rupture, which is very serious, will lead to tamponade, and sometimes it's fatal, or leading to pseudoaneurysm. This is less fatality than the tamponade itself when ventricular rupture. Ischemia to papillary muscle may lead to acute mitral regurgitation, and of course arrhythmias. Sometimes it's very dangerous, like ventricular tachycardia, ventricular fibrillation, bradyarrhythmias, and heart block may complicate acute myocardial infarction. And of course, acute pericarditis is a complication which is not so serious like the previous one. Late complications. Number one is recurrent ischemia. The patient may re-infarct once again, which is very dangerous. Ventricular aneurysm, if you have a lot of dead myocardium and less of fibrous tissue, then they may lead later on to ventricular aneurysm, mural thrombi, and systemic embolization, especially if you have ventricular aneurysm or cardiac neurosis that the patient is afraid to get another attack. We are getting to the near end of our lecture today. We must speak a little bit about the management of non-STEMI. Of course, non-STEMI is a very broad category, and the patient of non-STEMI, he may be, you may have on the extreme very high risk patients and low risk patients. You should differentiate between both, because of our aim here is rapid and effective relief of acute ischemia to prevent complication and to prevent deterioration to STEMI. If you are going to neglect the high-risk patients of non-STEMI, this may lead to going to STEMI, because in non-STEMI, there is a trickling of blood inside the coronary artery. It's not completely occluded. There is somehow some perfusion to the myocardium distal to the affected site of the coronary artery. So you must relieve the cause of acute ischemia. Of course, if it's imbalance between myocardial demand and supply, you may go and correct the cause. But here it's very important to classify the patient into, to know whom are the very high risk patients and whom are the low risk patients. So risking score is very important to guide therapy. We have the TIMI score and GRACE score. Every one of you have a smartphone, go on the net and get write GRACE score. You'll have the category and fill the blank, and you may categorize the patient according to the score. But you still want to know whom are the very high risk patients that need special attention and need so once again, the very high risk patients, those patients that need to go to the cath lab within 2 hours. You shouldn't wait for the patient and leave him in the intensive care unit more than 2 hours before get him to the cath lab. Those patients with hemodynamic instability and cardiogenic shock, a patient presenting to you with severe hypotension and signs of systemic hypoperfusion, this patient, of course, is in high risk, and leaving the patient may lead to sudden cardiac death, or the patient may go to STEMI. Number two, patients with recurrent ongoing chest pain despite medical treatment. Giving the adequate medical treatment in the emergency room and still the patient have severe chest pain, you shouldn't wait very late to take the patient to the cath lab. Patients presenting with life-threatening arrhythmias like ventricular tachycardia and of course ventricular fibrillation, patient went into sudden cardiac death and had a DC shock. You shouldn't leave the patient because this may endanger his life. Patients presenting with mechanical complications such as acute mitral regurgitation and patients with acute heart failure with refractory angina, you shouldn't leave the patient and should get him to the cath lab for definitive treatment. Patients with recurrent dynamic ST wave changes, especially if there is intermittent ST elevation. These are very high risk patients and may go to complete myocardial infarction. These patients, all these very high risk patients, should go to the cath lab within 2 hours to get their definitive treatment. Then you must know also whom are the patients at a high risk. These patients should go to the cath lab within 24 hours for definitive treatment. Whom are these patients? Patients with rise or fall in cardiac troponin compatible with myocardial infarction. So you are suspecting that the patient has high, severely elevated troponin or cardiac enzymes consistent with myocardial infarction. The patient should go to the cath lab within 24 hours. Patients with dynamic ST or T wave changes, also these patients may go to STEMI if leaving him more than 24 hours before getting his definitive treatment. Patients with a high GRACE score, high means more than 140, getting the GRACE score and filling all the categories of the patient. If you get a score more than 140, then this patient is a high-risk patient. By this, I think we have covered all the important issues in acute coronary syndrome, as well as you are knowing now who are the patients that you can call him patient with a chronic stable angina and patients with unstable angina. So go and read, and good luck. Thank you very much.